Alterations in integument, skin, hair, and nail disorders. Dermatitis is inflammation of the skin. There's two types that include an allergic contact dermatitis in clients that are sensitive to one or more substances, and primary irritant dermatitis that occurs from a chemical exposure. It may include a localized or a generalized rash. These clients have some dilation of the blood vessels along with itching or pruritus and blistering. The treatment involves removing the substances or substance that causes the irritation by flushing the skin with cool water, applying topical lotions or corticosteroids, or wet dressings. Nurses should wear rubber gloves if contact with chemicals. Maybe encourage a second laundry rinse if the culprit is determined to be laundry detergent. Encourage the avoidance of substances that could potentially cause dermatitis until it is determined exactly what that causative agent might be. So true or false? There's many different etiologies for dermatitis. This is false. There's a lot of different allergens that can result in dermatitis, but it is an allergic reaction to a specific substance. Acne is not on your core curriculum, but because it's such a prevalent condition, I included it here. Acne is a skin condition that commonly begins in adolescence and can last into adulthood. It affects the sebaceous glands and hair follicles and results in an overproduction of sebum. These clients may have an oily scalp, they may have the comedones and pustules. Treatment involves gentle facial cleansing, drying agents, topical oral drugs, antibiotics, removal of the comedones or pustules with instruments, dermabrasion, which removes surfaces of scarred skin. Nurses need to encourage these clients to keep their skin and hair clean and to avoid using oily products on their skin. Specific foods or habits don't particularly cause acne. So chocolate or poor hygiene, eating junk food, those do not cause acne. Rosacea is another item that's not on the core curriculum. However, this really is a pretty significant issue with some people. It is a chronic skin disorder that's characterized by a rosy appearance. The cause is unknown, but it might be caused by bacteria or mite infestations. These clients have an increased blood flow that lasts from hours or days and eventually becomes chronic. It can develop unevenly thickened and distorted skin surfaces. In fact, some clients, especially men, will develop that very large bulbous nose and can become very disfiguring. They can suffer from intermittent blushing, papules, pustules, facial swelling, rhinophyma, which is that enlargement of the nose. It also includes reddening and a nodular surface. There is no cure for rosacea, but treatment may involve minimizing symptoms, oral antibiotics, topical medications, and a pulsed light treatment to help improve appearance. It's very important to determine the triggers, minimize the sun exposure in these clients, and teach basic skincare regimens. A furuncle is a boil. White multiple boils is furunculosis, and a carbuncle are boils in which we have pus draining. These are caused by skin infections, also associated with diabetes mellitus. These clients have a painful pustule that's surrounded by erythema, fever, anorexia, weakness, and malaise. It's important to apply hot-wet soaks, antibiotics. We may need to do a surgical incision and drainage known as an I&D. Nurses teach strict aseptic technique and teach to not pick or squeeze those sites. We also need to encourage the washing of any cloths that are used around those sites separately, and use bleach when you are laundering them to help prevent that infection from hanging around. True or false? Furuncles, furunculosis, and carbuncles are treated with antibiotic therapy. This is true. Remember, these are infectious processes. Cellulitis is a common bacterial skin infection that causes redness or swelling and pain in infected skin, in the infected area of the skin. The bacteria gets into the body through small openings in the skin. Those openings may be very, very minuscule and difficult to see. The skin becomes reddened, swollen, and painful. It's warm to the touch, and it can have a pitted look like the peel of an orange, or maybe even have blisters, fevers, and chills. We treat it with antibiotics and keeping those wounds clean, also using good hand hygiene. Psoriasis is a chronic, non-infectious inflammatory disease in which there is an excessive proliferation of skin cells. Plaque psoriasis is the most common type. The cause is unknown, but it is likely that there is a genetic predisposition, and this also requires a triggering mechanism and may have an immunity component. There are some people that may have systemic effects of this disease, such as psoriatic arthritis. These clients have erythema with silvery scales and lesions. There is no cure for psoriasis, and we do treat symptomatically. There are some drugs that may be administered, some biologic therapies, and we may also do photochemotherapy. There's two different infestations that we'll talk about. The first one is scabies. This is an infestation that is caused by tiny itch mites. It's spread by skin-to-skin contact, but it does not involve poor hygiene. The mite will burrow into the upper layer of the skin where it lives and lays its eggs. It causes intense itching, and because of that itching and that scratching, we see excoriation. We treat it with scabicide applications, thorough bathing, clean clothing, and avoiding contact with those that are infected. Nurses need to advise that the itching can continue for 2 to 3 weeks after treatment. All clothing or items that may harbor the itch mite have to be washed in hot water, and sometimes we may use bleach in that water. Pediculosis is an infestation with lice. It's transmitted also through direct contact or sharing of personal items, such as combs, brushes, or clothing. We see an itching of the scalp. We may, on inspection, see brown crawling insects the size of sesame seeds, or small yellowish white ovals that are the nits attached to the hair shafts. We can also see small gray nymphs. Those silvery eggs, once again, are attached to the hair shaft. So you have to really get down close to the scalp to see the nits themselves. We treat it with pediculicides, mechanical removal. Lice, however, are developing some strains that are resistant to chemical extermination. Nurses need to educate on detection. Do not use hair conditioner prior to the application of the pediculicide. All people in the home should be inspected for lice. All clothing the client has come in contact with, all bedding and furniture have to be treated. So wash the clothing and the bedding, vacuum the furniture and the carpets. And these bugs can live for a long time. Dermatitis are superficial parasitic fungal infections, also known as tinea, and they're more commonly known as ringworm and athlete's foot. They invade the skin, scalp, and nails. We see rings of papules or vesicles with a clear center, pruritus, and sore skin. We treat it with oral or topical antifungal agents. These clients have to use separate towels, washcloths, grooming articles. They cannot share clothing. They have to dry thoroughly after bathing. Fungus loves warm, dark, and moist. Clients should avoid tight-fitting clothing, and for example, they need to wear footwear when they're in a public or community shower to help prevent contracting it or help prevent spreading it. Herpes zoster is more commonly known as shingles, and it's caused by the varicella zoster virus, the one that causes chickenpox. And this virus remains dormant in the body for years. And then there's something that sets it off, something that triggers it. So they have the virus ever since they've had chickenpox, and then something triggers it, and now they have shingles. So basically what happens is that reactivation of the varicella virus, zoster virus. The symptoms occur in one or more cranial or spinal nerve routes and can cause eye ulcerations, vertigo, and permanent hearing loss or stroke. What happens is we have a raised, fluid-filled, and painful skin lesion with inflammation in what we call a dermatome, which is skin that is supplied by a particular nerve. These clients also have itching, and they may have post-herpetic neuralgia. In other words, pain that continues even after the herpes lesions are gone, and this pain can actually continue for years. Antiviral medication, if it is administered within 48 hours, can actually lessen the severity or prevent additional lesions from occurring. We may see symptomatic treatment such as pain medications. We also need to encourage vaccinations. Nurses should discourage contact with people that have not had chickenpox. Cool or warm compresses, whichever feels the best, and the wearing of loose clothing would be really important for comfort. There's 3 types of skin cancers. They're classified as non-melanoma or melanoma. Non-melanoma skin cancer risks include sun exposure or tanning bed use, especially in clients that have a tendency to sunburn. fair skin with freckling, light-colored hair and eyes. The male gender is more prone, and cigarette smoking. So the first non-melanoma skin cancer is basal cell carcinoma. These are painless, round, nodular lesions that may have a pearly appearance. They grow slowly and they rarely metastasize. We treat it with surgical excision. Mohs surgical procedure, MOHS, is a procedure in which thin layers of the cancer-containing skin are progressively removed and examined until only cancer-free tissue remains. We can also do a procedure called electrodesiccation and curettage, cryotherapy, radiation, or drugs that are applied topically or maybe even injected into the lesion. Topical chemotherapy, again, is for these non-metastasized basal or squamous cell cancers and prevention of some other skin cancers. Adverse effects include irritation at the treatment site that can last for weeks or months after treatment concludes. These clients have to avoid direct sunlight or exposure to UV rays during the entire treatment period. We may see pain, itching or burning, flushing, loss of skin, crusty skin, or dry skin. One of the main examples that we talk about is the Fluorocell. The squamous cell carcinoma are scaly ulcers or flat and raised lesions. They can also be caused by overuse of tobacco and alcohol. They develop on those sun-exposed areas, including the lips and in the mouth. They do grow rapidly and they can metastasize. Treatment may include surgical excision, cryotherapy, and radiation therapy. Melanoma. This is caused by increased exposure to ultraviolet rays, radiation, and the fair skin, of course, increases that risk. Melanoma arises from the pigment-producing cells in the skin. It is the most serious form of skin cancer, and it can be fatal if it metastasizes. It's found anywhere on the body. They have irregular borders and uneven coloration. Many of them are dark, but some are light in color. They begin as a tan macule that begins to enlarge. These clients may see a new appearance of a growth, or they may see changes in the skin color itself. We treat it with electrodesiccation, surgical excision, cryosurgery, radiation therapy, chemotherapy, and immunotherapy. One of the drugs that we use to treat melanoma is interferon. Alpha is the best known class, but there's also beta and gamma classes of interferon. We use biologic response modifying drugs that are classified as cytokines. These augment or enhance the immune system. The major dose-limiting factor with interferon is fatigue. Because it causes such extreme fatigue, it's going to be what we base our dose on. It is usually administered by injection, so it's important to rotate the injection sites as we would with any repetitive injection. Adverse effects include flu-like symptoms, fatigue, tachycardia, hypotension, nausea, vomiting, diarrhea, neutropenia, where we lose those white blood cells, thrombocytopenia, where we lose platelets, and confusion. So as nurses, when we're talking about melanoma, we follow the ABCDE for melanoma identification. A being asymmetry, B being border irregularity, C is the color is not uniform, D, we have a diameter greater than a pencil eraser, E, an evolving change in the lesion. These clients should also be instructed to use sunscreens and lip balms that have sunscreens, wearing a hat with a wide brim, staying in the shade, avoiding artificial tanning, and avoiding prolonged sun exposure between 10 a.m. and 4 p.m. when the ultraviolet rays are strongest. Actinic keratoses are precancerous lesions that are generally found on the face, neck, forearms, and the backs of hands. In other words, basically areas that are frequently exposed to sunlight. They can become malignant if they're not treated or followed up on. It is most common in white, older adults. They do appear as papules or plaques of irregular shape. The hard scale on the lesion can shed and reappear. Treatments include drug therapy, cryotherapy, surgical excision, or electrocodesiccation. Seborrhea and dandruff are non-inflammatory conditions, sometimes accompanied by seborrheic dermatitis, which does have an inflammatory component. Seborrhea is caused by excessive secretions from the sebaceous glands. The scalp is the primary site, and dandruff can also be caused by a fungus. We see oily hair, red or scaly patches on the scalp, white flakes from the hair, and itching. We treat it with frequent shampooing with or without medicated shampoos, corticosteroids. Nurses need to advise of the shampooing need and potential for the condition to recur. And nail disorders. Nails are subject to disorders including fungal infections or ingrown toenails. Fungal infections can easily spread from one nail to the other, including the toenails. We may see elevated, thick, distorted, loose, or yellow friable nails. We treat it with prolonged systemic drug therapy, nail removal, and surgery. We encourage compliance with drug therapy, alternate the shoes that are being worn daily, do not go barefoot, and wearing footwear at public pools and showers. Ingrown toenails will usually occur on the inside edge of the great toe. They can be caused by an inherited trait, a fungal nail infection, or improper shoe fit or trimming of the nails. These clients have swelling, redness, pain, maybe purulent drainage, and odor. Important to treat the infection: soaks with warm water or Epsom salts, sometimes lifting that edge of the nail, or surgery might be required to remove the edge of the nail. Foot soaks, relieving pressure around the nail, in other words, proper footwear. Seeing a podiatrist if diabetes is an issue, if they have vision problems or vascular problems, should all be encouraged by the nurse.